Right, so a very good evening to everyone. I welcome you all to this particular YouTube session. So, right, I am very much aware that everyone is completely in a stressed and tensed state, but it is the very crucial time where you need to be very strong and you have to maintain your mental stability and as well as confidence at this moment of time. So, without having a lot of stress in your brain, I definitely wish that you should have a very peaceful night today, and I will finish the class in another 1 or 1.5 hours. After this particular class, right, have a comfortable rest of nearly around 6 to 7 hours and go to your exam tomorrow morning with a lot of peace in your mind. Don't get overstressed. You have prepared extremely well until now, and you have read multiple times all the subject. So be confident enough that you will definitely clear the exam this attempt. All right. So this is an FMGE final wrap-up session for your tomorrow's exam. Now, what is that I will be teaching in this session? So in this session, I will be discussing some of the images, which are very important images, which are expected images for your tomorrow's exam. All right. Now, let us start with the first question. And at this moment of time, if you are unable to recall any particular images, please don't worry. I will be just teaching you in such a way that these are some of the expected questions for the tomorrow's exam. Okay. First question. Which clinical sign is being elicited? Hoffman-Tinel sign, Hoffman reflex, tabletop sign, prayer sign. Which clinical sign is being elicited in this patient? So you can just see that right. So you can see that the middle finger of the individual is being flicked with the thumb of the examiner. So what do you think is this particular sign? Hoffman-Tinel sign, Hoffman reflex, tabletop sign, the prayer. Right. And let me see who will be the first person to answer this question. Yes, anyone? Just 1 second, I'm very sorry. Okay, so this is your Hoffman's reflex, right? This is your Hoffman's reflex. It is not your Hoffman-Tinel sign, it is your Hoffman reflex. Now, what is this? Let me explain you. The Hoffman reflex, right? The Hoffman reflex, it is, right? It tells you that it is the presence of the upper motor neuron lesion. And this Hoffman reflex, it is similar to that of your plantar reflex of the lower limb. right? It is similar to that of your plantar reflex of the lower limb. And if the Hoffman's reflex is positive, right? If the Hoffman's reflex is positive, what does that tells you? That tells that the individual has the upper motor neuron lesion, right? That tells that the individual had an upper motor neuron lesion. That is what is the importance of your Hoffman reflex. Now, some of you are getting confused with the Hoffman-Tinel sign. Hoffman-Tinel sign, it tells you about the median nerve injury, right? It tells you about the median nerve injury. That is what is your Hoffman-Tinel sign. Now, where will be this Hoffman-Tinel sign will be positive? The Hoffman-Tinel sign will be positive in case of the carpal tunnel syndrome, right? The Hoffman-Tinel sign will be positive in case of the carpal tunnel syndrome, right? And you take the prayer sign. I'll just show you the prayer sign as well and Hoffman-Tinel sign also. Now, how do you elicit this Hoffman-Tinel sign? See, this is your Hoffman-Tinel sign. What you need to do? You need to tap over the median nerve which is present over the wrist. Right? You need to tap the median nerve which is present over the wrist. Now, once you tap the median nerve over the wrist, if there is the tingling sensations within the arm of the individual or within the hand of the individual, that tells the Tinel sign is positive. So, which is suggestive of the carpal tunnel syndrome, right? Which is suggestive of the carpal tunnel syndrome. Now, this is your prayer sign. So now where do you see this particular prayer sign? Prayer sign, it is seen in patients with the diabetes mellitus, right? It is seen in patients with the diabetes mellitus. And this is nothing but your diabetic chiropathy, right? So we call it as diabetic chiropathy. So in diabetic chiropathy, you will have a limited joint mobility. Right, in diabetic chiropathy, you will have the limited joint mobility. So that is what is your prayer sign. So this is a prayer sign. Prayer sign is seen in case of diabetes mellitus. And this is nothing. Why do you have this? This is due to limited joint mobility. So this is what is called as prayer sign. Now, I will just show you the next important image. Yeah. Which test is performed in this patient? Gordon sign, Hoffman sign, ankle clonus, Oppenheimer sign. Yes, any one of you? Right, so what is being tested in this patient is the ankle clonus, right? So what is being tested here is the ankle clonus. So how do you elicit the ankle clonus? You need to catch hold of the calf muscle with one hand, right? And you need to catch hold of the ankle with the other hand. Then you need to give, right? You need to give a sudden jerk, right? You need to do a sudden dorsiflexion. If there is presence of the ankle clonus, there will be jerking movements within the ankle. That is what is called as ankle clonus. And if ankle clonus is positive, that tells the presence of upper motor neuron lesion, right? That tells the presence of the upper motor neuron lesion. So that is what is your ankle clonus. Okay, right. Now let me just show you the other signs also. Hoffman sign, already I have said you. What is this Hoffman sign? It is also telling you the presence of the upper motor neuron lesion, but Hoffman sign, we elicit it in the upper limbs. Just now, the previous image, what I have shown you is the Hoffman sign, right? The previous image, whatever I have shown you is the Hoffman sign, okay? Next, followed by that, what is this Gordon sign? What is this Oppenheimer sign? Gordon sign and as well as the Oppenheimer sign, you see this is your Gordon's and this is your Oppenheimer sign. These two are the alternative methods of eliciting the plantar reflex. Right? These two are the alternative methods of eliciting the plantar reflex. Okay, so that is what is your Oppenheimer's and as well as the Gordon reflex. Now, what will you do in Oppenheimer's? In Oppenheim sign, you will rub over the shin of the tibia. Right? You will rub over the shin of the tibia. So when you rub over the shin of the tibia, there will be extension of the great toe and fanning out of the other toes. Right? There will be extension of the great toe and fanning out of the other toes. That is what is your Oppenheim sign. Right? That is what is your Oppenheim sign. Next, you take the Gordon's. Now, what is Gordon's? You need to squeeze the calf muscles. Right? So Gordon's is what? You need to squeeze the calf muscles. And if there is upper motor neuron lesion, then you will have extension of the great toe and fanning out of the other toes, which is nothing but your Babinski sign. So now remember, Oppenheim and as well as Gordon's, what are those? They are the alternative methods of eliciting the plantar reflex. Normally, you will elicit the plantar reflex by using a blunt object. With the help of a blunt object, we will give the stimulus from lateral to medial side over the plantar surface. And if there is upper motor neuron lesion, then there will be extension of the great toe and fanning out of the other toes. That is what is the elicitation of, that is what is your regular method of eliciting the plantar reflex. Whereas Oppenheim and as well as the Gordon, these are the alternative methods of eliciting the plantar reflex. Okay. So in the question given to you, which test is performed in this patient? The ankylosing. What is Gordon and as well as Oppenheimer? Gordon and Oppenheimer's are the alternative methods of eliciting the plantar reflex. What is Hoffman sign? Hoffman sign is elicited within the upper limbs. Okay, and that also tells you if Hoffman sign is positive, that also tells you the presence of the upper motor neuron lesions. Okay, so that is about this particular multiple choice question. Yes, this is one of the very, very important image, right? And very frequently asked questions in your exams. A 65-year-old patient of ST elevation MI underwent thrombolysis with streptokinase. The ECG tracing performed after thrombolysis is shown below. What does it exhibit? Ventricular bigeminy, accelerated idioventricular rhythm, ventricular tachycardia, Wenke-Back phenomenon. Yes, and let me see who will be the first person to answer this. So, Shahid Afridi says Wenke-Back's phenomenon. It is not Wenke-Back's phenomenon. The answer is very good, Bhargavi. The answer is accelerated idioventricular rhythm. Right? The answer is accelerated idioventricular rhythm. Now, what is this accelerated idioventricular rhythm? Accelerated idioventricular rhythm is the one which will appear in the ventricle after thrombolysis. Right? After thrombolysis in a patient with the ST elevation MI. Now, what will be the features of this accelerated idioventricular rhythm? Number one, they will have bradycardia. Right? Number one, they will have bradycardia. Okay. Number two, there will be absence of the P wave. Right? The P wave is absent. Number 3, they will have a wide QRS complex. Right? They will have a wide QRS complex. Number 4, they will have this rhythm after thrombolysis. Right? They will have this particular rhythm after thrombolysis. Okay. So that is what is the accelerated idioventricular rhythm. That is what is your accelerated idioventricular rhythm. So bradycardia will be there. Heart rate of the patient is only 40. Wide QRS complexes will be there. The P wave will be absent, right? And this bizarre appearance is called as slow. Slow in the sense bradycardia is there. How much is the heart rate? Only 40. Right? How much is the heart rate? Only 40. So that is about your accelerated idioventricular rhythm. So remember, the appearance of the accelerated idioventricular rhythm, it tells that the individual had a successful thrombolysis. Right? The individual had a successful thrombolysis. Okay, so that is the importance of your accelerated idioventricular rhythm. All right. Next, we will move on to the next question. Now, if you want me to explain the other options, like ventricular bigeminy, how will be the ECG of ventricular bigeminy? This is the ECG of the ventricular bigeminy. Right, this is the ECG of ventricular bigeminy. So how is this? This is the normal complex and this is an ectopic. Right, this is an ectopic. So you see here, this is a normal complex and this is an ectopic. This is a normal complex and this is an ectopic. So how is the ECG of ventricular bigeminy? Every alternative complex is an ectopic. This is an ectopic. This is an ectopic. This is an ectopic. So every alternating complex, it is an ectopic. That is called as the ventricular bigeminy. Right? That is called as ventricular bigeminy. Now, you had one more thing in your options, that is VT, ventricular tachycardia. Now, I will show you the ECG of ventricular tachycardia. This is the ECG of your VT. This is called as monomorphic VT. Right? This is called as monomorphic ventricular tachycardia. Right? Monomorphic ventricular tachycardia. So what will be the features of VT? There will be wide complexes. Right? There will be wide complexes. And if you take the rate is nearly around 300 per minute. Okay, rate is around 300 per minute. And you will have only QRS complexes. There is no P wave. Right? There is no P wave. That is what is the feature of the VT, ventricular tachycardia. Now, why there is no P wave? Why there is no P wave? Because in case of VT, the impulses are originating only from the ventricles. Right? Why is it called VT? Because the impulses are originating directly from the ventricles. That is the reason why you don't have the P wave. Okay? Right. Now you see the next ECG. This is the ECG of your WPW syndrome. Right? This is the ECG of WPW syndrome. That is Wolff-Parkinson's-White syndrome. Now, what are the features of WPW syndrome? The features of WPW syndrome include, number 1, short PR interval. Right? There will be presence of short PR interval. And there will be wide QRS complex. Right? There will be presence of wide QRS complex. And there will be presence of a delta wave. Right? There will be presence of the delta wave. Okay? So this is your delta wave. Right? So how will be the appearance of the delta wave? There will be slurring of the QRS complex. Right? There will be slurring of the upslope. Right? There will be slurring of the upslope of the QRS complex. So that is what is your WPW syndrome. Okay. So WPW syndrome, what are all the features? Short PR interval, wide QRS complex, presence of the delta wave, and upward slurring of your QRS complex. Okay. So now after having discussed about all the features now, so what is this? This is suggestive of, right? This is suggestive of the accelerated idioventricular rhythm. And among the options which are given to you, I have shown you the ECGs of all the other options also. All right, next. Now you see the next question. Pulmonary function test they have asked you last time, but I am not sure whether they will be asking you this time or not. But anyways, this is another important question. Hypermobile thumb, right? Hypermobile thumb is characteristic feature of Marfan syndrome, Ehlers-Danlos syndrome, Weil-Marchesani syndrome, Klinefelter syndrome. Hypermobile thumb is the characteristic feature of Marfan's, Ehlers-Danlos syndrome, Weil-Marchesani syndrome, Klinefelter syndrome. Right. So all of them, like, okay, mainly your Marfan's and as well as the Ehlers-Danlos, right? They are your connective tissue disorders. Hypermobile thumb, you will have this in case of the Ehlers-Danlos syndrome, right? Hypermobile thumb. Okay, so the answer is not Marfan's, the answer is the Ehlers-Danlos syndrome. So in Ehlers-Danlos, like what are all the other abnormalities the individual will have? The other abnormalities what the individual can have is the kyphoscoliosis, hypermobile thumb, right? And if you take the skin of these individuals, they will have a translucent skin, right? So that is what is the features of your Ehlers-Danlos syndrome. And it is in case of Ehlers-Danlos where you have the presence of the hypermobile thumb. And what is that you will have in Marfan's? In Marfan's, you will have a very long fingers that is called arachnodactyly. Right, that is called arachnodactyly. That is what you will see in case of Marfan's. You will not have the hypermobile thumb in case of the Marfan's. Right, and you will have what is called thumb sign, but you will not have hypermobile thumb. In Marfan's, you will have thumb sign. What is thumb sign? Whenever you make a fist, this particular thumb, it comes out of the fist, right? It comes out of the fist. That is what is called as thumb sign. Now, why do you have that thumb sign in patients with the Marfan's? Because of the presence of arachnodactyly. Because of the presence of arachnodactyly, they will have this particular thumb sign. But the answer to this question is the Ehlers-Danlos syndrome, the presence of hypermobile thumb. Okay. Now, we will move on to the next question. Yeah. Which one of the following is the diagnosis of the X-ray? In the sense, X-ray given to you, what is the diagnosis? Pneumonia, ARDS, lung abscess, bronchiectasis. Right, and let me see who will be the first person to answer. So, you see both the lungs. So what is that you are seeing in both the lungs, right? So it's a complete, right, very good, Santosh. So the answer is B. So you are having a complete florid pulmonary edema throughout the lungs. So this we call it as whiteout lungs. Right, so this we call it as the whiteout lungs. Okay, so where do you have this complete whiteout lungs? That you will have in patients with the ARDS, right? Acute respiratory distress syndrome. Now, can anyone tell me what is the most common cause of ARDS? what is the most common cause of the ARDS? Right. So the most common cause of ARDS is sepsis. Right. The most common cause of ARDS, it is sepsis. Okay. Next, we will move on to the next question. Right. And this is the chest X-ray of your lung abscess. This is a chest X-ray of your lung abscess. Okay. So in case of lung abscess, you have the presence of a very thick wall surrounding the abscess. And not only that, how will be this abscess? The abscess, there will be presence of non-homogeneous opacity. Right, presence of non-homogeneous opacity. Okay, right. So that is about the lung abscess. Yes. Now, yeah. So this, you see this question, very, very important. Clinical feature of this patient most commonly will be, right? So ECG is given to you. Clinical feature of this patient most commonly will be severe chest pain, palpitations, dyspnea, cough with expectoration. Right. So what is the diagnosis of this particular ECG? The diagnosis of this ECG is, right, the diagnosis of this ECG is presence of pulmonary embolism. Right, pulmonary embolism. Okay, so in pulmonary embolism, now why are you telling it is pulmonary embolism? You have that classical feature of the ECG of pulmonary embolism, that is S1, Q3 and T3 pattern. Right, S1, Q3, T3 pattern. So the presence of this S1, Q3, T3 pattern, that is suggestive of your pulmonary embolism. Right, that is suggestive of your pulmonary embolism. Okay, now the other point is, in pulmonary embolism, what will be the most common symptom? In pulmonary embolism, the most common symptom will be dyspnea. Right, in pulmonary embolism, the most common symptom will be dyspnea. Okay, so that is what is the clinical feature of the patient. So prominent S wave in lead 1, Q wave in lead 3, and T wave inversion in lead 3. That is what is called as S1 Q3 T3 pattern. And S1 Q3 T3 pattern, it is not present in all the patients with the pulmonary embolism. This S1 Q3 T3 pattern, it is present only in 7 to 10% of patients with the pulmonary embolism. Now, if the question is asked, what is the most common ECG finding in patients with the pulmonary embolism? The most common ECG finding in patients with the pulmonary embolism will be sinus tachycardia. Right, sinus tachycardia. So sinus tachycardia, it is the most common ECG feature in patients with the pulmonary embolism. Right, most common ECG feature in patients with the pulmonary embolism is sinus tachycardia. Okay, right. Now, after having discussed about the pulmonary embolism, now we will move on to the next question. Yeah. Following X-ray is suggestive of Hampton's hump, Pallas sign, Western mark sign, McConnell sign. Following X-ray is suggestive of. So you observe the X-ray there, right? An arrow is also marked. Okay, you see this is the arrow. An arrow is pointing towards a structure which is right. So yeah, so this is your Pallas sign, right? This is your Pallas sign. Okay, so what is this particular Pallas sign? Prominent right descending pulmonary artery. Right, so prominent right descending pulmonary artery, that is what is your Pallas sign, right? That is what is your Pallas sign. Okay, and where do you have this Pallas sign? This particular Pallas sign is seen in patients with a pulmonary embolism, right? It is seen in patients with the pulmonary embolism, right? Now you take the other images, I mean the other options. I will also show you the image of Hampton's hump. I will also show you the image of Western mark sign, and I will also show you the image of the McConnell sign. Now let me show you the Hampton's hump. Okay, so this is your Hampton's hump, right? This is your Hampton's hump. So what is there in the Hampton's hump? The presence of wedge-shaped infarct, right? The presence of a wedge-shaped infarct. That is what is called as the Hampton's hump. Presence of a wedge-shaped infarct is called Hampton's hump. And where do you see this particular Hampton's hump? This is also seen in patients with the pulmonary embolism, right? This is also seen in patients with the pulmonary embolism, right? So that is what is your Hampton's hump. Now, yes. Now you see this is your Western mark sign. Now what is that Western mark sign? Western mark sign, it is also seen in patients with the pulmonary embolism, right? Western mark sign is also seen in patients with the pulmonary embolism. And lastly, the McConnell sign, right? Lastly, McConnell sign. McConnell sign, it is the 2D echo, right? The 2D echo feature of pulmonary embolism. Now, what is that? In case of McConnell sign, what is that you will have is the apex of the right ventricle will contract. Apex of the right ventricle will contract, whereas the wall of the right ventricle does not contract. Wall of the right ventricle does not contract. That is what will happen in patients with the pulmonary embolism, and that is called as the McConnell sign. Only the apex of the right ventricle will contract, whereas the wall of the right ventricle does not contract, and that is what is suggestive of your pulmonary embolism. Okay, so that completes the discussion of all these particular options which has been given to you. So Hampton's hump, Pallas sign, Western mark sign, McConnell sign. All these, where do you see? All these we see in patients with the pulmonary embolism, out of which Hampton's hump, Pallas and Western mark, they are the X-ray findings, and McConnell sign, it is a two-dimensional echocardiographic finding, right? Next. Yes, see this is one of the very, very important image. Which of the following is a characteristic finding in this X-ray? Meniscus sign, deep sulcus sign, tram track sign, signet ring sign. which of the following? Very good, Santosh. So the answer to this question is right. So the answer to this question is the meniscus sign. Right, it is your meniscus sign. So the presence of Ellis S-shaped curve. Right, presence of Ellis S-shaped curve. That is what is called as the meniscus sign. Where do you see this deep sulcus sign? Where do you see this particular deep sulcus sign? Deep sulcus sign, you will come across this in patients with the pneumothorax. Right, you will come across this in patients with the pneumothorax. Okay. Now, you take the other images also. Tram track sign, you will see this in tram track sign and signet ring sign. Both of them, you will see this in patients with the bronchiectasis. Right, both of them you will see that in patients with the bronchiectasis. Right, now, so this is your tram track sign. Right, so in case of bronchiectasis, the bronchi are abnormally dilated, and that abnormally dilated bronchi, if you do an imaging study, that will be in the form of a tram track. That is called as tram track sign. Yeah, type of respiratory failure in this patient is type 1 respiratory failure, type 2 respiratory failure, type 3 respiratory failure, type 1 respiratory, type 4 respiratory failure. Type of respiratory failure in this patient is so first of all, you should be able to tell the diagnosis of this image. No. Right. So this image, it is suggestive of emphysema. Right. This image, it is suggestive of emphysema. Okay. So how are you able to tell that it's an emphysema? You see, both the lung fields are abnormally large. So when both the lung fields are abnormally large, and if you take the tubular, the heart is like vertical or tubular heart. Why? Because both these abnormally enlarged lungs will overlap the heart. Right? Both these abnormally enlarged lungs will overlap the heart. And not only that, if you take the diaphragm, you will have the presence of the low set diaphragm. Now, why do you have that particular low set diaphragm? That is because these abnormally enlarged lungs will push the diaphragm down. Right? These abnormally enlarged lungs will push the diaphragm down. So that is the reason why you will have this abnormally enlarged lung fields with diaphragm being pushed downwards. So the type of respiratory failure in patients with emphysema, it is your type 1 respiratory failure. Right? Type of respiratory failure in patients with emphysema, it is type 1 respiratory failure. So type 1 respiratory failure, it is characterized by hypoxia. Whereas carbon dioxide levels, if you see, either there may be normal or they are reduced. Right? The carbon dioxide levels, either they are normal or reduced. So that is what you will see in patients with the type 1 respiratory failure. Then what about in type 2 respiratory failure? In type 2 respiratory failure, you will definitely have hypoxia. Along with that, there will be hypercapnia. Right? And where do you have this type 2 respiratory failure? So you will have this in patients with the chronic bronchitis. That is another subtype of COPD. One subtype of COPD is emphysema, where you have type 1 respiratory failure. The other subtype of COPD is chronic bronchitis. You will see that type 2 respiratory failure in chronic bronchitis. Okay, so the type of respiratory failure in this patient is type 2 respiratory failure. Right, now we will discuss some more images. Yes, you see this question. A 35-year-old man presented with progressive myoclonus. MRI was done. What is the diagnosis? Herpes simplex encephalitis, subacute sclerosing panencephalitis, variant Creutzfeldt-Jakob disease, mesial temporal lobe sclerosis. Just 1 second. Right. So I hope now you can see the question. I have just changed it. Yeah, you see the options. Patient presenting to you with progressive myoclonus, apathy, MRI was done. What is the diagnosis? Herpes simplex encephalitis, subacute sclerosing panencephalitis, variant Creutzfeldt-Jakob disease, mesial temporal lobe sclerosis. Right, very good. So Vanilla has answered, Naidu Vanilla. So the answer is the variant Creutzfeldt-Jakob disease, right? So now how can you tell it's a variant Creutzfeldt-Jakob disease, right? The reason is that if you take the MRI, what is that MRI showing? The MRI is showing the presence of the cortical ribboning, right? So the presence of the cortical ribboning along with progressive myoclonus and apathy, it is seen in case of the variant Creutzfeldt-Jakob disease. Whereas you take the herpes simplex encephalitis, it involves the temporal lobes, right? Now what is that you are seeing in the image? It is not just only temporal lobes, right? It is the entire cerebral hemisphere which is affected. And you take subacute sclerosing panencephalitis, it is commonly seen in children. Right, it is commonly seen in children. But what is the age of these individuals? 35 years. Next, mesial temporal lobe sclerosis. This mesial temporal lobe sclerosis, the presentation of the patient will be in the form of focal seizures. Right, the presentation will be in the form of the mesial temporal lobe sclerosis. The presentation will be in the form of focal seizures in case of the mesial temporal lobe sclerosis, right? So that is what you will see in this patient. So the answer in this question is variant Creutzfeldt-Jakob disease. Why is that? Due to the presence of the cortical ribboning and the presentation of the patient in the form of progressive myoclonus and apathy. Now you see this question. 1-year-old child presented with myoclonic jerks. EEG is done. What does it shows? Normal record, hypsarrhythmia, periodic spike and wave pattern, burst suppression pattern. So this is one of the very, very important EEG. Right, so this is one of the very, very important EEG of the hypsarrhythmia. Right, so what is that you will have in case of hypsarrhythmia? You will have high voltage and slow waves. Right, so you will have high voltage and as well as slow waves. That is what you will see in patients with the hypsarrhythmias. Right, high voltage and as well as the slow waves. Yes, this is another important image. A 60-year-old man presented with history of memory loss and fatigue. On examination, he has bradykinesia and axial rigidity. Resting tremor is absent. Patient had a broad-based gait with the tendency to fall. MRI is done, right? In the MRI also, an arrow is marked over the lesion. All are true about the condition except. All right, so if you see this question here, the individual had bradykinesia and as well as the axial rigidity, but resting tremors, they're absent, right? Resting tremors, they are absent. This is suggestive of atypical Parkinsonism, right? This is suggestive of atypical Parkinsonism. Now, what is that particular form of the atypical Parkinsonism? That form of atypical Parkinsonism, no, I did not. Okay, so I think whoever has answered D, right? Whoever has answered D, right? Those students are correct. That is intracranial hypotension will not be there. Now, what form of atypical Parkinsonism is this? Now, if you observe closely, the MRI, it is showing the presence of the hummingbird appearance. Right, the MRI, it is showing the presence of the hummingbird appearance. So now where do you have that particular hummingbird appearance within the MRI of the brain? So you will have that in patients with the progressive supranuclear palsy. And in progressive supranuclear palsy, remember, there will be a poor response to levodopa, correct? Gaze palsy will be there, correct? Pseudobulbar palsy will be there, correct? But intracranial hypotension will not be there. Right, intracranial hypotension will not be there. So the answer to this particular question is intracranial hypotension, because what is the question asked? The question asked is except. So the answer is intracranial hypotension. Now we will move on to the next question. Right, which of the following syndromes is shown below? Weber syndrome, Millard-Gubler syndrome, lateral medullary syndrome, Anton syndrome. Weber, Millard-Gubler, lateral medullary syndrome, Anton syndrome. So you should know at which level the brain is being cut. So these are all your brainstem stroke syndromes. The brain is cut at the level of the midbrain. Very good, Mohammad Karimuddin. So Mohammad Karimuddin is answered it correctly. So the brain is cut at the level of the midbrain. Okay. Now, sir, how can you tell it? Right. This is your third cranial nerve. This is your third cranial nerve. So third cranial nerve, where will you see if the brain is cut at the level of the midbrain? Because the third cranial nerve nucleus is present within the midbrain. Now, what has been damaged here? Now, what is this structure? This structure is your pyramidal tract. So your pyramidal tract is damaged and the third nerve is gone. So this is a green mark is the site of lesion. Right? Green mark is the site of lesion. Okay. So what are the structures damaged? This is your pyramidal tract which is damaged. And this is your third nerve which is being damaged. Right? So pyramidal tract lesion and third nerve lesion. So where will you have that? You will have that in patients with a Weber syndrome. You will have that in patients with Weber syndrome. Right? Next. Yes. Now you see the next question. Yeah. Which cranial nerve will be spared in the lesion shown below? 8th, 9th, 10th, 12th cranial nerve. So first of all, you should be able to make out the brain is being cut at which level. So if you understand the exact cut section of the brain, where exactly it is being dissected, then you will understand which particular cranial nerves will be involved, which will not be involved. Devaraj has answered it correctly. So the answer is the 12th cranial nerve. Right? The answer is the 12th cranial nerve. So remember 8th, 9th, 10th. Okay, 8th, 9th, and as well as 10th. These three cranial nerves, what is actually the image showing? The image is showing the presence of lateral medullary syndrome. Right? The image is showing the presence of lateral medullary syndrome. Okay. In lateral medullary syndrome, this is also called Wallenberg syndrome. So the cut section which is being shown to you, right? The cut section what is being shown to you, it is at the level of the medulla oblongata. Right? Sir, how can you tell it is at the level of the medulla oblongata? You can see these are all your cranial nerve nuclei. Right? These are all your 8th, 9th, 10th, 11th, 12th cranial nerve nuclei. Okay. So where do you have this 9, 10, 11, 12 cranial nerve nuclei? They are present at the level of the medulla oblongata. And lateral part of the medulla oblongata is being cut. Right? So you see the red mark, whatever is showing you here, that is the lateral part of the medulla being cut. That is called as lateral medullary syndrome. Also called Wallenberg syndrome. And the vessel which is involved in case of this lateral medullary syndrome or Wallenberg syndrome, it is your vertebral artery. Right? It is your vertebral artery. So it is the vertebral artery which is being affected in patients with the lateral medullary syndrome or the Wallenberg syndrome. Right? It is the vertebral artery which is being affected in lateral medullary syndrome or Wallenberg syndrome. And in lateral medullary syndrome, the cranial nerves which are gone are 9, 10, 11, and as well as 8. 12th cranial nerve is not affected in case of the lateral medullary syndrome. The 12th cranial nerve, remember, it is affected in case of medial medullary syndrome. Right? It is damaged in case of medial medullary syndrome. Okay. Medial medullary syndrome, this is also called Dejerine syndrome. Right? Also called Dejerine syndrome. And in medial medullary syndrome, the vessel that is being blocked is your anterior spinal artery. Right? The vessel which is being blocked in the medial medullary syndrome is the anterior spinal artery. Okay. So in medial medullary syndrome, 12th cranial nerve is affected. And the image which is shown to you is the lateral medullary syndrome. So that is the reason why the answer is the 12th cranial nerve. Okay. Now, I'll just show you one last question and then we will wind up this session. Yes. Medial medullary syndrome leads to blockade of which of the following blood vessel? A, B, C, D. Right? So I have given you the image of the circle of Willis, both anterior and as well as posterior circulation. Now from this, you should be able to make out. Now in my previous question, when I was discussing, there I have taught you that medial medullary syndrome is due to the blockade of the anterior spinal artery. Now you identify the anterior spinal artery in this particular circle of Willis. You identify which is your anterior spinal artery. A, B, C, D are the options. Right, so whoever has answered B, right, very good. So Ash has answered B and Devaraj also answered B. So this is your anterior spinal artery, right? This is your anterior spinal artery, and whatever the C is being mentioned here, that is your vertebral artery, right? That is your vertebral artery. And what about A and as well as D? Your A is your pica, posterior inferior cerebellar artery. And what is your D? That is your ICA, anterior inferior cerebellar artery. Okay, so you should know the exact labeling of the circle of Willis also, and accordingly the question will be asked, right? So medial medullary syndrome is due to the blockade of the anterior spinal artery, and in the circle of Willis you should be able to identify which is your anterior spinal artery, right? So this is an important image, and these are some of the image based questions which can be expected in your tomorrow's exam, right? So I wish all the best to everyone for tomorrow's exam. And one important take home message for the tomorrow's exam is that whenever you are solving the questions, even though if you are not able to solve 4 to 5 questions continuously, please don't get worried and please don't get depressed in the examination hall itself, thinking that continuously 4 to 5 questions I am unable to solve, right? What about the remaining part of the paper? Okay, please be with a positive attitude in the exam. Please maintain your mental stability. Whatever the hard work you have done all these 3 months or 4 months, that all completely will be taken care in that particular 3 hours. In that 3 hours, if you maintain your complete mental stability, the exam will go on very smoothly. Please don't get stressed. Please don't get depressed. Please don't get worried whether I will pass this exam or not. That particular flow of negative thoughts should not be there for you in the examination hall. And sleep early today, and tomorrow morning whenever you are going, please don't forget your hall ticket, and please don't forget your ID card. And these two are very, very important, your hall ticket and as well as the ID card. It should be an original ID card. Either it might be an Aadhaar card or your voter ID or license. So please don't forget this, because we have seen some of the students in the previous sessions, because they forgot the ID card, they were not allowed into the examination hall. So please don't do this mistake and don't miss the exam because of this particular silly reason. So please be stable in those 3 hours, and that means in the morning 3 hours and the afternoon 3 hours. Please be stable. If you are mentally stable during that particular examination time, you can definitely crack the exam. Okay, so with this, a small take home message, I will wind up the session, and I wish you all the best. You will definitely crack the exam, and all of us, let's crack this particular FMGE exam. And after the exam, please post the questions of general medicine, and definitely I'll come up with the discussion of the FMGE question paper discussion. Okay, I wish you all the best, and see you again in the upcoming sessions for the live discussion of the FMGE question paper. Thank you very much. Good night and stay safe and stay healthy.